When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Good evening. Welcome to Dr. Gore's show. Today, it's my pleasure to invite Dr. Shubha Verma to the show. Dr. Shubha Verma started her career in Delhi, and she did her training in medicine, and then she came to New York where she did her residency in general surgery. She went on to do a fellowship, which is a special training in vascular surgery in UMDNJ in New Jersey. And now she is an assistant professor in Columbia, and she is head of vascular department at Palisades General in New Jersey. Welcome to Dr. Gore's show.
Thank you, Dr. Gore.
So vascular surgeon, they're a little bit different than cardiothoracic surgeon because they take care of the blood vessels which emerges from the heart or goes back to the heart and which supplies the whole body.
Right.
So you guys take care of all those veins and arteries?
Right. So vascular surgeons, first of all, I must make it clear that vascular surgeons don't just do surgery. A large percentage of our patients are managed medically without operations, and only some of them then go on to require vascular surgery. So vascular surgeons deal with arteries and veins, other than the arteries of the heart and the lungs. We deal with the arteries and veins all over the body, including the arteries to the brain for stroke prevention or treatment of stroke surgery, as well as aneurysms, as well as other arterial blockages that may develop in patients, because of which they may have either pain in their legs or ulcers or what have you.
Right. So the arteries are the ones which carry the oxygenated blood from the heart to the rest of the body.
Right.
And veins are the ones who take the deoxygenated blood after the oxygen has gone, return it back to heart to be oxygenated in the lung.
Right.
Now, both the arteries and veins are your specialty.
Yes.
And the disease of those two vessels are different.
Yes.
So we can start with the diseases of the arteries.
Okay.
So as you said, the artery to the brain,
Right.
I suppose that's the most important one to keep us awake and alive and function. So what are those arteries, and what are the common diseases that affect those arteries going to brain?
So when we look at diseases relating to the brain, we are specifically talking about four main arteries: the carotid arteries, the right and the left, as well as the vertebral arteries, which are in the back, and there's again the right vertebral and the left vertebral artery.
Okay.
And these arteries are very important, especially the carotid arteries, in that if plaque builds up within these arteries, that can be one of the main causes for causing a stroke in a patient.
Okay.
So, and again, the stroke can be because of two different reasons. One is that if a bit of a plaque breaks from the artery and gets pushed up further by the blood going onwards into the brain, it can then cause damage to an area of the brain which is being supplied by that particular artery, and that patient will lose function.
Correct.
From that part of the brain.
So the part of the plaque which is dislodged from that blood vessel, when it goes and gets stuck in the smaller vessels, correct? Because this is a big one.
Right.
And when it gets stuck, so the part of the brain which is supplied by that small blood vessel is going to lose its function depending upon how long and how much is the blockage.
Right.
So how do those people present to you?
Well,
To the emergency room.
right. So there are, again, like I said, there are two different ways coming back to that. One is where the plaque breaks off and it's called embolizing. It embolizes to the brain, where the brain loses function. Or the second is where there is such tight narrowing of the arteries that not enough blood is able to get to the brain.
Right.
So again, these two different reasons for having a stroke manifest in different ways.
Okay.
Typically, when it's an embolic stroke, a patient is well 1 minute, and then the next, he or she develops a symptom where it could be something very minor, like they may have a feeling of as if a curtain has come on their eye, or they may have some slurriness of speech, which goes away, or it may just be something that they felt like they slept wrong and an arm feels different or a leg feels different. So, or it could be a complete paralysis of one side of the body. Right. So typically, the carotid, when the carotid disease causes a stroke, it will affect one side of the body. Usually, if the right carotid artery is the problem, usually the left side of the body will be affected. Right. So, stroke can present in many, many different ways, from very mild or completely just lasting for a few minutes to a permanent loss of function.
So what's a TIA? We commonly hear things like TIA. What's a transient?
So TIA stands for transient ischemic attack, and usually when the symptoms resolve within the first 24 hours, then it is referred to as a TIA.
So that is the definition. Reversible
usually it is a reversible condition. It does, however, predict an increased risk of having another stroke, which may or may not be a TIA, which may be a more major stroke. So it is, in itself, it does disappear over 24 hours, but it is a predictor of further
what might to come.
What is to come, right.
So as we were discussing it before the show, you very rightly pointed out that vascular disease is just not one part of the artery. It's right. like your whole body, right. because this is what is showing us. But this is because of your diet, your cholesterol, your diabetes. So when you diagnose somebody that they do have either TIA or they have some issues, because of some sort of stroke, what do you do? Like, how do you investigate to look for the causes? What are the investigations? What are the predictors to see like when they might need some intervention by you to take care of that plaque or embolization?
Sure. So the evaluation of a patient that we might think has vascular disease begins with a very thorough history and a physical exam. Mm-hmm. And in the history, we specifically ask questions regarding family history. Is there a history of stroke mm-hmm. in any family member at a young age, especially if there is a history of early heart attacks at a young age, or if there is a history of previous blood clots, that also, or even patients that have, say for example, female patients, if they are young, mm-hmm. if they've had if any symptoms suggestive of neurological dysfunction, and if they've had previous multiple miscarriages, for example, that could point us also in the direction of that person has some sort of generalized vascular disease, which is causing them to have early manifestations of neurological disease. Then, of course, history of diabetes, history of hypertension, history of heart attacks, history of previous strokes, very important, as well as history of smoking. All of these things. And then in the family history, if they've had history of previous DVTs or multiple family members have previous DVTs, then they have certain inherited conditions right. Which can be present, which are leading the patient to have manifestations of neurological disease. And it is really important to get that very detailed history to be really able to manage that patient well, medically as well as surgically. Then once we have the detailed history, we go on to the physical exam. And again, vascular disease is usually a systemic disease. Correct. Even if we find disease in one part, we do have to look for disease in the rest of the body, because typically a patient that has a blockage in one place is more than likely to have blockages elsewhere, and right. it's better to pick them up.
Is there any value, going back to my med school, I'm dating myself now, we used to listen for carotid bruit, like we would put the stethoscope and listen to it. Does it have any value in today's day of Dopplers? Like, do you guys listen?
Yes, we do listen, and it does have value. The presence of a carotid bruit will sometimes be able to pick up an asymptomatic patient, right. a person that has never had a manifestation of carotid blockage, right. but we can pick it up by a carotid bruit. Mm-hmm. Again, if the carotid bruit is present, it does not mean that they are going to have right. Disease that needs to be fixed. However, and its absence does not mean that disease is absent, right. but it is part of a full physical exam, and it's
just like a red flag.
Yes,
that maybe
it is.
You have it.
And we would screen somebody.
Correct.
We do not routinely screen everybody for carotid disease mm-hmm. With a Doppler. because there are cost implications, and the yield is so poor. If we were to screen everybody for carotid disease, the yield is poor. It doesn't warrant screening everybody for that test. But if the patient has risk factors, if the patient has had previous symptoms, or if the patient has a carotid bruit or any other risk factors, then it makes sense to screen them even before a neurological event has occurred.
Correct. So after we examine them, what are your typical investigations you'll do to figure out if there's any issue here?
Typically, a carotid ultrasound is a very, very good study, and to pick up extracranial disease, which means disease that is located in the neck. It does not pick up intracranial disease, and it does not pick up diseases in the thoracic cage, so that it picks up only the carotid disease in the cervical area.
Which is external, not the hidden arteries.
Right, and fortunately these are the most common parts of the arteries that are affected. Right. So we do pick up the vast majority of
patients
blockages in these arteries. So a carotid Doppler, which is performed in a proper lab with a good technician, is actually a very, very good test. Now here the caveat is that it is very technologist dependent.
Correct.
So for example, if a technologist is not well trained, or if the Doppler machine is not a good quality Doppler, people can have, they can be led the wrong way, where they can miss a stenosis, or they can overread a stenosis, overdiagnose it. So that is very important, that it be done at a proper place and be read properly.
Right. So say you found, is there a critical number that you are looking for, that up to that number it's okay to manage, say, get down their cholesterol or get their diabetes under control, but after a certain blockage, maybe you might have to intervene?
There are numbers, and there have been large clinical trials that have been performed. And typically for asymptomatic patients, in other words, patients that have not had any neurological symptoms within the past 6 months. So if somebody has had a stroke 10 years ago, that is really not considered a symptomatic patient.
Correct.
So if a patient has had symptoms within the past 6 months, symptoms including either a TIA or, like I said, a curtain falling across the eyes, or a full stroke, and they have a stenosis of 50% or more, would be considered as patients that would benefit from surgery. Or if the patients never have had a stroke, but have been investigated by an ultrasound for whatever reason, and they are found to have a stenosis of 80% or more, are generally recommended that they undergo treatment. And again, it depends upon what the quality of life of the patient is, how functional they are,
what kind of job they do, and how it's affecting their day-to-day work. So in simple terms, say we found, either 80% blockage or 50% blockage, what kind of procedure in general you can do? Like, I know there might be some specific things, but do they need a cut, or you can go through the vessels and kind of peel that plaque away? How does that work?
So there are there are three mainstays of therapy. One is the medical management, where a plaque is monitored. The patients are placed on antiplatelet medications, as well as cholesterol-lowering medications. And if they're smokers, they're asked to stop smoking. Their hypertension is controlled. And those patients can be monitored. If they are very high risk, then that treatment can be offered to them, obviously under a very strict surveillance program. Also now there are other studies that can be performed where what kind of a plaque is it? It becomes very important. So if it is a fibrous plaque with very little embolic potential, where there is a nice layer covering the plaque and very little chance that a piece of it is going to break off, those patients may be managed medically and with antiplatelet agents and all the other medical treatments. Then surgically there are two main lines of treatment. One is the standard, the gold standard, which is a tried and tested operation, which is called a carotid endarterectomy. And in that operation, we do have to make a cut. And basically, the procedure involves cleaning out the insides of the artery, the plaque, and closing the artery either primarily, or we put sometimes a patch, which can be a piece of vein that's taken from the patient's body, or it can be a prosthetic patch that's placed. And now, relatively new, however not very new now, is the procedure called the carotid stent. And that is very similar to the procedure
Cardiac.
as for the heart.
Right.
And basically all of it is performed through the artery in the groin, and using fluoroscopy and x-ray, a metallic stent is placed in the artery, and what that stent does is it opens the lumen of the artery, number one, and number two, it changes the flow lumen. So in other words, if there is an embolic surface which is irregular, has plaque deposit on it, it changes the lining of the inside lining of the artery.
So it can't get detached.
Right, so it can't, embolize anymore.
Right. So do these patients after the procedure, they tend to be on a special medication to take maybe through life along with the blood pressure, diabetes, and lifestyle changes? Do they need something like antiplatelet agents that they have to monitor and continue?
Yes, we do recommend that patients continue antiplatelet agents. If we have treated them with a stent, then for 30 days after the procedure, we recommend aspirin and Plavix, which is also an antiplatelet agent. Otherwise, for an open operation, usually just aspirin suffices.
All right. I think we're going to take a quick break and we'll be coming back, so don't go anyplace.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Welcome back. Today we are talking a very, very common and important topic of vascular disease. As we get older and we get diabetes and blood pressure, especially with our Indian population, we tend to get both of that. And if you add smoking to that, it increases our risk for vascular disease. And to talk about that, we have Dr. Shubha Verma from Columbia. So we talked about the arteries of neck and above. Let's talk about the legs, because that's some things that you see it commonly.
Sure.
And how do those people present? Do they come to you, or they go through their medical doctor, or plastic, or skin? How do they come? How do you get those referrals?
Well, we see a very wide spectrum of patients with arterial diseases of the legs, and often patients ignore them because they attribute the pain in their legs to either arthritis or old age or something that they just have to live with, until it becomes an ulcer or a wound, or the toes become discolored, and that's when they start getting worried. Correct. And that's when they seek advice. So in the Western population, we see them sometimes more frequently as the knowledge of the diseases is more. People tend to seek treatment sooner. So one of the earliest manifestations of vascular diseases, if a patient notices that with a certain walking distance, they begin to get cramps in their legs, and that cramp then goes away as soon as they sit down. And then as soon as they start walking again, the cramp comes again. And usually it will occur in a specific muscle group. So it's not scattered all over the body, it will be in a particular muscle group, and that pain that occurs is reproducible with exercise and goes away with rest.
So it's a different pain than your knees and your joint pains. It's a muscle pain, and that should warrant somebody to look into. Maybe it's not just arthritis or old age. So that's kind of like a trigger question. You'll ask about claudication. Where exactly is your location of your pain?
Right. And often these patients just, instead of seeking help, they just keep on limiting their activities further and further and further. They start walking less, they start limiting whatever they can do, they start using the car more often, and that is actually the opposite of what they should be doing. Because walking actually improves the circulation and the movement of blood cells through the muscle capillaries. So it's good to have that in the back of your mind if you're having such symptoms, to at least ask your doctor, does it need to be evaluated? Then as as the vascular disease progresses, there may be constant pain. And usually that pain occurs in the toes or in the small part of the foot where at night, typically where the patients are horizontal, the gravity is not working in their favor, and they have such advanced circulation problems that the nerves, the fine nerves in the foot get affected, and then as soon as they lie down they start having pain, and when they put their feet down the pain goes away.
Right.
So that is the next level. And the last level, of course, of severity of vascular disease in the legs is when the toes either frankly start turning gangrenous or wounds form that just take months and months and months and don't heal. And that is, that is when the
severe.
patients actually come and see us, because that's very painful, and that they don't want to see any open wounds on the foot.
Of course.
Right.
So once you've seen that person, is the investigation so history most likely will be the same. You're going to examine for the pulsations and stuff. Is the investigation a little bit different, and the management of course will be slightly different than the carotid, correct?
Right. So here again the history is very important, especially history of smoking and history of diabetes, very important. Patients that have diabetes are much more likely to develop symptoms of vascular disease than non-diabetic patients. And in fact, if a patient has diabetes for over 10 years, not only is their circulation affected, but their nerves are affected as well. So they don't feel, if they step on a nail, they may not feel that they're stepping on something sharp. They may not feel any pain.
Right.
They may not notice a wound that's on their foot, which becomes larger and larger. So diabetes is very, very important in patients that have with this vascular disease. Smoking as well. Smoking also affects at multiple different levels. It's not just the circulation, it's also how thick the blood is, how sticky the platelets are,
right.
and so on. All of those things affect how the blood is flowing into our system.
Right.
And so all of those things are very important, and we really like to get a good sense of what really is happening with the patient's physiology,
right.
so that we can treat them effectively.
So those are the two major culprits for the peripheral vascular disease. So as you said, the diabetes is such an important topic, and we bring it up again and again, but people who suffer from diabetes definitely should go and see a podiatrist or a foot doctor. Sometimes they have to get their nails clipped by somebody. That's how there's less trauma and less chance of infection and stuff. So again, not only for the foot care, but as we discussed, the vascular disease, it's so important with diabetes that they feel the nerves, even if the nerves are affected, to keep this flow going, that way they prevent. And we've seen in India amputation and people really having issues if these vascular diseases are not taken care of.
Right. What is very important and is often ignored is the patient education. And I have seen that in many of the patients that they don't have any idea of what really diabetes does to them.
Right.
They have had diabetes for 10, 15 years. But if they are taught that they have to inspect their feet almost on a daily basis, they have to wash their feet well, they have to avoid any dry skin, and they have to keep their skin really moisturized so that the little cracks that form in the dry skin, which is where infection starts,
right.
That can be avoided, or to always wear cotton socks. Or be very careful when they buy new shoes, because of their nerves being affected, they don't feel the pinch. They don't feel
if the shoes are too tight.
If the shoes are too tight. So typically they should wear wider shoes with soft soles, and it's worth every dollar that if they have to spend extra on that, because it's really taking care of their feet and avoiding all the hassle of going through, if a wound forms, it just becomes a much bigger deal in a different
And
situation.
as we discussed earlier, the leg might be one of the things which it's easy to see with diabetes and vascular problem, but that blood vessel disease is affecting their retina, their vision, their kidneys. So those vascular disease affects the whole body as such, and that's why they are higher risk for kidney failures and blindness and heart attacks and stuff like that. I think we can talk on and on about this vascular disease. In short, I want to touch also the veins, because especially as an OBGYN, we are very concerned with blood clots in the veins and birth control pills affecting the clotting in the veins, or pregnancy by itself. As we discussed earlier, some families tend to have some sort of issue called antiphospholipid syndrome, where they have the tendencies to make the blood clots without any trauma, or most people, if they are immobilized, they have, say, fracture or hip surgery, and then they get blood clots. this families tend to get it without much of provocation. So tell us what's a deep vein thrombosis, how it differs from the superficial ones, correct?
So deep vein thrombosis, as the term implies, is when there is a blood clot that forms within the deep veins. And the significance of deep vein thrombosis becomes obvious when either the patient has pain, which is because of the local formation of the blood clot, where the blood is not able to flow back up into the heart, so that the extremity gets swollen. So either it presents as that, or once in a while it can present as something called a pulmonary embolism, where a little bit of the clot gets dislodged, and then the patient may experience shortness of breath, chest pain, or they may cough up blood, or they may even pass out if it's to a very severe degree. So, but those are the main reasons that we worry about blood clots. Is number one, is it going to increase and go further up and involve more of the extremity, or is it going to move up into the lungs and it can be fatal? It can even cause somebody to have a sudden death.
Sure.
So that's in short what and when it affects the superficial veins, where the veins you can see underneath the skin, that's usually called a phlebitis, and that is that may be related to either intravenous blood draws, or they may have had an intravenous there. Sometimes it can happen even without any
or varicosities.
Varicosities
can make them prone for it. So usually when do we collaborate with you to take care of DVT? Usually it's a medication with blood thinners in most cases, but when does your specialty come into play? When those clots are big, or they have traveled somewhere, or they have got it repeatedly in spite of thinning?
In this day and age, the standard of care for a deep venous thrombosis involving the lower extremities, especially in young or middle-aged patients, is to seek vascular, or other specialists also take care of this, but basically the treatment now is to dissolve the blood clot.
Right.
So blood thinning by itself is not complete treatment.
Okay.
Blood thinning prevents further progression of the clot.
Right.
But what happens with that is that the valves that are present in the veins do get permanently destroyed.
Right.
And those patients go on to develop something called the post-phlebitic syndrome, where they have chronic swelling of their legs for the rest of their lives.
Because they've become insufficient.
Because the valves have become insufficient. So now the goal of therapy is actually, if we can diagnose it early, then we try to dissolve the blood clot.
Even though those vessels seem so tiny and harmless, there are things that it can do to one's brain or heart or legs, and leading to lungs can be really with a very, very bad outcome. So I really thank you for coming, taking time off from your busy schedule and enlightening us on this vascular disease, which affects so many of our Indian population. Good night.
Thank you, Dr. Gaur. Thank you for having me.
Thank you.
Good night.
My pleasure. Good night. Till next time.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.